So I'm going to introduce the next speaker, Dr. Jyoti Panwar, who completed an MSK Radiology Fellowship at UHN. And currently, she's pursuing a diagnostic neuroradiology fellowship at UHN, University of Toronto, which she'll complete in June 2018. She did her radiology residency in India and worked for some time as a radiologist. She's published more than 35 reviewed papers in PubMed, indexed scientific journals, has presented 5 papers and 8 to 10 posters at scientific meetings. Currently, she's involved in neuroradiology research projects, including post-concussion syndrome with Dr. Michaelis and Tatter. She's also involved in MSK research projects. She's a member of the special interest group from the MRI in GIA in OMERACT, and currently is leading the whole brain MRI group under the guidance of Dr. Doria. Here's Dr. Panwar. I guess, come on.
Thank you for your introduction. So I'm going to talk about our study on the prevalence of structural lesion on conventional MRI in a large prospective cohort of post-concussion syndrome patient, and we are trying to establish a neuroimaging criteria for the same. So there are like a different and sometimes conflicting diagnostic criteria have been proposed by multiple professional organizations for the acute and chronic phase of mild traumatic brain injury. However, all these criteria require that the patient should have an external impact on the head, and that will be followed by some alteration in the brain function. So mild traumatic brain injury is the most commonest form of TBI and accounting for about 75% of all TBI reported cases. And although the concussion and MTBI have been used interchangeably by most of the medical practitioners, but there has been a recent growing trend that concussion should be reclassified as a less severe form of MTBI. So sports injury account for most of the cases in young adults, but the other etiologies included motor vehicle crashes, falls, assault, and military combat. Majority of the patients with concussion, they recover within 1 to 4 weeks following the traumatic event, but a subgroup of patients who do not fully recover in the specified period of time and will continue to have symptoms beyond the initial 1 to 3 months are called to have a post-concussion syndrome. So according to one author who has described the full spectrum of the concussion or mild TBI, and we can see in this image, there is a progression of severity. Sorry, I'm just looking at the mouse. Yeah, I don't know whether it's working. It's not projecting over here. Maybe I can use this one. So I can use the pointer.
All of that's for the computer in the back. It's your
Okay, so yeah, I'm good. So we can see here there's a progression of the severity of the spectrum. So starting from the subconcussive blow through the concussion, simple MTBI, to the most severe form, that is complicated MTBI. So currently, ideally, all this entity would have a specific diagnostic criteria or objective biomarker separately, but currently, this exists only for the complicated MTBI, and that is positive imaging finding on CT and MRI. And this is for the acute phase. For the chronic phase, they have included the chronic traumatic encephalopathy and prolonged post-concussive symptoms. It has been believed that chronic traumatic encephalopathy is a diagnosis which is made on postmortem diagnosis, and there is no in-life criteria to diagnose this entity currently. So, multiple professional organizations have used different diagnostic criteria to diagnose MTBI, and presence of imaging finding on CT and MRI have been used as a exclusion criteria from, you can see here, it has been used from 2009. So PCS. PCS commonly occurs after multiple episodes of concussion. According to one study, Tata et al. Has said that it can occur after a single episode of concussion in 23% of subjects. According to this paper, median duration of PCS was 7 months, ranging from 1 month to 26 years. So they have proposed the diagnostic criteria, which includes at least 3 symptoms persisting for, from the list of 40 symptoms persisting for at least 1 month. So those patients who do not meet this criteria or have a more severe injury, which include the presence of hemorrhage, cerebral contusion, and focal neurological deficit have been excluded from this study. So these are the list of the persisting symptoms of the PCS, and it is in the decreasing order. So most commonest symptoms were headache, memory deficit, concentration difficulties, imbalance, dizziness, and fatigue. Similarly, multiple organizations have proposed their different criteria and definition for the PCS. So according to ICD-10, it requires the positive history of TBI. Patients should have at least 3 symptoms persisting for more than 1 month post-injury out of this list. And similarly, DSM-4 in 2000 has used the similar criteria, except that the patient should have a symptoms more than 3 months post-injury with significant social decline. In 2012, Concussion in Sports Group have used the criteria for symptoms persisting for more than 10 days. So coming to the neuroimaging for this disease entity have been divided into structural imaging and functional imaging. Structural imaging include CT and MRI. CT is a gold standard for imaging acute TBI because it has a low cost and it is quite sensitive in detecting the acute blood component and fracture related to MRI. But on the other hand, MRI is quite sensitive in detecting the structural lesion or presumed traumatic etiology, like the cerebral contusion, microhemorrhages, especially the RN-sensitive sequences like gradient echo and susceptibility-weighted imaging is very sensitive in detecting tiny amount of blood within the brain, like microhemorrhages, cortical cirrhosis. Functional imaging include the diffusion tensor imaging, MR spectroscopy, functional MRI, SPECT, and PET. By looking at this graph, we know there is an increased public awareness about this disease entity, and we can see here the number of research articles related to MR imaging of MTBI and concussion has been grown exponentially from 2005. So you can see the curve, how it is growing since 2005. And still we can see the conventional imaging is the main way of diagnosing this concussion and MTBI on imaging. And the advanced imaging, which is still in infancy, or we can say it is a research tool. So despite of all this, we do not have any conclusive imaging criteria for the PCS. And there is a great variability in the frequency of the structural abnormality reported on imaging in literature. That because everybody used their own criteria, or there is a different diagnostic criteria for these subjects. So they might have used like a patient with more severe instead of like a mildest form of the MTBI. So to combat this problem, we are trying to do one study, and the aim of our study was to investigate the nature and frequency of structural lesion on conventional MRI in a large prospective cohort of PCS patient. This study was approved by Institutional Review Board, and all the patient has given consent for this study. PCS subjects were compared with the age and sex matched healthy controls. The inclusion criteria included all the PCS subjects have had at least 1 concussion, the minimum period of more than 1 month since the last concussion, and diagnosis of PCS was based on the clinical criteria alone. On the other hand, all the patient less than 13 years has a positive brain disease with a known injury greater than PCS on imaging, like evidence of contusion or hemorrhage on the prior imaging have been excluded from the study. For the control group, if there was a positive history of the head injury or brain disease were used as the exclusion criteria. So all these subjects, like including the PCS and healthy control, underwent 3 Tesla MR examination by using the uniform standard MRI protocol, which include the 3D T1 weighted imaging. So it is a volume imaging, and then T2 flare axial and blood sensitive sequence, that is gradient echo imaging. And both, like all the MR examination were read by like 2 fellows like myself and my colleague Charlie Shu, who has reviewed all the MRI, and then we, like all these differences were with final agreement by the consensus. So all the MRI were evaluated for the presence of contusion, microbleed, cortical siderosis, presence and number of the white matter hyperintensities, presence of diffuse or regional atrophy, and incidental findings. So white matter hyperintensities were counted and recorded categorically as a 0, number ranging from 1 to 10 and more than 10. And further, location of these white matter hyperintensities were also recorded as either as a subcortical location, which is like equal or less than 3 millimeter, or more than 3 millimeter, as recorded as a deep white matter high signal. So we'll be seeing subsequently in the next image. Like, for example, you can see here, this is a flare sequence image. There is a white matter high signal, and this white matter high signal was spotted on the 3D T1 imaging. And then further, we can see here that the shortest distance between the adjacent gray white matter interface to the surface of the white matter has been recorded. So in this patient, it was 1.2 millimeter. And because it was less than 3 millimeter, it was recorded as a subcortical white matter high signal. So coming to the results, 135 PCS patients were included in the study, with 78 male and 57 female, with the mean age of 33, while control group consisted 29 subjects, with male 19 and female 10, with a mean age of 36 years. So we can see here there's average 3.5 concussion for all these PCS subjects, and the mean duration of the PCS and mean time to MRI was 17 months. 41 subjects had a loss of consciousness, and amnesia was observed in 29, and both were observed in 19 subjects. And again, we can see contact sports and recreational mechanism of injury was the most commonest mode of injury. Coming to the imaging result, like majority of patients had a normal MRI, like 97% of patient had a normal MRI. Only the structural finding, which was presumed of traumatic etiologies, were present in 4 patients. So we can see here the contusion was present in 2 patients, and contusion was 2 patients, and microbleed was present in another 2 patients. And just wanted to highlight that white matter hyperintensity was more common in PCS as compared to the control, but it was not statistically significant. And in the PCS subjects, this white matter hyperintensity was more located in the subcortical location, which is expected for the concussion or MTBI. So these are the 2 patients where we saw the contusion. So it's one subject, the contusion was located in the anterior temporal pole, and the other patient, it was in the left orbitofrontal lobe. So by looking at the imaging, it seems like this patient have an injury more than the mild. And maybe based on the clinical diagnosis and history, it was difficult to diagnose the PCS in these 2 patients. But when we look at the imaging, it looks like a patient had a severe, like more than the mild injury, which has resulted into the contusion. So we can exclude these 2 patients by looking at the imaging. So to make the PCS subgroup more homogeneous, we require some imaging criteria. So if you have a finding on imaging, we can say this patient did not have a mild or mildest form of the injury. It is more than the mild injury. And these 2 subjects has a microhemorrhages. The one patient had a microbleed in the pons, and the other patient had in the posterior periventricular white matter. There are some limitations applied to our study. Firstly, the MRI protocol utilized the T2 gradient, which rather than the susceptibility with imaging, which is more sensitive in detecting the microbleed. The other one was we did not use the more advanced structural or functional neuroimaging modality, so it is possible that early microstructural changes following the traumatic event might have been missed. The sample size of the control group was relatively small, hence the group comparison were not as strong as that could have been in a study of this size. So our findings showed that the structural lesion in PCS are extremely uncommon in this selected group of patients, and the presence of such findings suggests a more severe form of traumatic brain injury. So based on our robust prospective data, we propose the following neuroimaging criteria for the PCS. First, absence of extracerebral hemorrhage such as subdural, extradural, and subarachnoid bleed. Second, the absence of intracerebral hemorrhages such as hematoma, contusion, and microbleed even on the blood-sensitive sequences, including both the gradient echo and SWI. And there should not be any diffuse or regional brain atrophy, and presence of white matter hyperintensity, irrespective of number, is not an exclusion criteria. These are my references. If you have any question?
I'd like to push the audiology standpoint one again. So for MRI, if we're not seeing lesions, then in audiology we do electrophysiology functional testing. So we might not be able to see by picture or MRI imaging any damage in the brain, but if we look at the functional aspect, because along with the vestibular system, the auditory system is can be quite impacted, and we just saw in the last talk, it hits the temporal lobes as well. So I don't know if you can look at electrophysiological responses to look at nerve function rather than imaging.
Yeah, I agree with you because it is more of the microstructural damage, so which can be evaluated more by the functional imaging or electrophysiological studies. So that is why that's one of the imaging criteria we say, like, we should not see structural finding on imaging. If we see, that means it is more than the mild injury, it is not concussion. Yeah.